Dean Ari, you may begin.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. I would like to express my warmest welcome to all attendees, panelists, and our guest moderator. It is such a great pleasure to have all of you join us virtually in today's AAHCI Southeast Asia webinar on the topic of understanding COVID-19 vaccines, filled with discussion revolving around COVID-19 vaccinations. I hope that everyone will benefit from fruitful discussion and that this will be an opportunity for further elaborative projects in the future. We are honored to have Dr. Louisa Sang, an infectious disease physician from Singapore, lead ID physician and head of infection prevention and control at Alexandra Hospital. She has a unique role in coordinating the full spectrum of the pandemic response and clinical management of COVID-19 patients in the hospital. Dr. Louisa is passionate about continuing medical education, and also she co-hosted the second season of the COVID-19 Update from Singapore webinar series organized by NUS Yong Lung Clean School of Medicine, with gathered international leading scientists, public health officials, and policymakers to discuss the latest insight concerning COVID-19. Please, Dr. Louisa, you may open this webinar. Thank you.
Thank you so much, Dean Ari, for the kind introduction, and a very good afternoon to all our participants today. And thank you very much for joining us this afternoon for this webinar, hosted by the AAHCI Southeast Asia Regional Office host, Universitas Indonesia. As Dean Ari mentioned, for the next hour, we are honored to be joined by 4 experts in their field who have all made great contributions in various domains in fighting the pandemic. They will each be sharing their experiences, lessons learned during the pandemic, as well as new knowledge of vaccine and booster development processes. Our speakers will each present a 10-minute section, and we encourage questions and discussions, but if we could have your kind understanding to leave that to our 30-minute Q&A section at the end of the 4 talks. And it is now my great pleasure to introduce our first speaker for today. Taking us through the topic COVID-19 Serosurveillance, a tool determining North Sumatera's transition to endemic COVID-19, is Professor Inke Nadia. She is a pediatrician from the Universitas Sumatera Utara, Indonesia, and currently the Vice Dean for Research, Community Engagement, and Collaboration at the Faculty of Medicine. Professor Inke has been actively involved as a member of the COVID-19 Task Force for North Sumatra Province, a member of the Monitoring and Evaluation of COVID-19 Drug Candidates Task Force for the Indonesian Ministry of Health, and a member of the Merah Putih Vaccine Acceleration Task Force for the Indonesian Ministry of Research and Technology. Professor Inke, please.
Thank you, Dr. Louisa, for a very nice introduction. And thank you again for the invitations. I will present on behalf of my team on our study about COVID-19 serosurveillance. Let me share my slide first. 1 second. Okay, so I will be presenting about COVID-19 serosurveillance, a tool determining North Sumatra's transition to endemic COVID-19. We all know that there are several countries nowadays starting to transition from pandemic to endemic, such as the UK, Denmark, Sweden, Singapore, and Malaysia. However, the status of a pandemic, epidemic, or endemic depends on interplay of a population's behavior, demographic structure, susceptibility and immunity, and whether viral variants emerge. Endemic refers to the constant presence or usual prevalence of a disease or infectious agents among population within a geographical area, and the overall rates, including the case rates, hospitalization rates, and death rates, has to be static. Well, but endemic does not necessarily mean mild. There are endemic diseases that kill 400,000 of people a year, like malaria, and there are also endemic diseases like HSV1, and where you can only get a cold sore. However, there are signs with high levels of populations with COVID-19 immunity, the severity becomes closer to that of seasonal influenza. And until today, there is still not a global formal set of criteria that can be used to determine when a pandemic becomes endemic. However, some criteria can be used to assess its risk, whether it causes severe illness and when it causes overwhelming healthcare system. So it does not only look at the infection rates anymore, but it also looks at the hospitalization rates, mortality rates, vaccine uptake among high-risk group, and evaluation whether sufficient immunity has developed in general population. So this is the trend of COVID-19 cases in North Sumatra province, where our university is based. North Sumatra province has 14 million of population. And in the past 2 years, we have two peak of cases. The first one in July, August 2021, due to the Delta variant. And the second one was just ended a month ago due to the Omicron. Nowadays, we can see the bed occupancy rates has decreased significantly, causing only about less than 5% of used bed in the hospitals for COVID-19. And when we look at the vaccine uptake among different age groups, the coverage of vaccine, COVID-19 vaccine ranging from 67% to 90%, showing that almost sufficient of COVID-19 vaccine coverage in all age groups. So our study aimed to determine whether our population has developed sufficient immunity to prevent severe diseases, therefore preventing an overwhelmed health systems. We analyzed our data by looking at different age group, vaccination status, and as well as the levels of antibodies developed. We performed the study in 7 districts out of 33 districts in North Sumatra province from January to March 2022. We analyzed all the samples in our microbiology laboratory at the Faculty of Medicine. And the participants who were included in the study were those who were residing in the districts within the past 6 months, and also those who were visiting the primary health centers. We performed structured interview. We also analyzed the antibodies, including the IgM, IgG, and neutralizing antibodies using the CLIA. So there were about 1,979 participants included in the study, and almost 45% were male. We divided the age group according to age group of recipient of COVID-19 vaccine in Indonesia. So those who are under 6 years old have not recommended to receive vaccine yet. And then the young age group, 6 to 11 years old, adolescent 12 to 17 years old, adults 18 to 59, and then elderly above 59. We also look at history of COVID-19 based on self-reporting and as well as from PCR tests, whether they did PCR and antigen tests, and we found about 7.5% of individuals interviewed reporting having COVID-19 infection in the past. We also look at the vaccination history among the participants. We excluded children, children under 6 because they have not received any vaccine yet. And among the rest, we found about 5.6% of individuals have not received any vaccine yet. 6.8% only received 1 dose. 56.2% have received 2 doses, and 31.4% have received 3 doses. Most of the participants received the second dose within 28 days after receiving the first dose, and also the average of 4 months after receiving third dose after the second dose. When we look at different vaccine use among these individuals, 96% of individuals use Sinovac as the prime vaccine and use Moderna as the booster vaccine at 69% of the individuals receiving the third dose. So our first evaluation was looking at the antibody of the immunoglobulin M, and our assay detected a range from 5% to 16% of individuals with positive immunoglobulin M. And because of the study was done just right before the Omicron arrived in North Sumatra, and just at the very beginning of the rising of the cases, we didn't expect of high positivity rate among different age groups. We found the higher positivity among children aged 6 to 11 and also among adults. The children, the recommendation for vaccination in children aged 6 to 11 just started in January. So most children in this group just started receiving their first dose or second dose in February. And also adults are more at risk for exposure for COVID-19. And we also compare the history of vaccination and history of infection with detectable antibodies. So among children under 6 years old who have not received any vaccine yet, we found already about 61.6% of them having detectable antibodies. And among children aged 6 to 11 years old, we found 93% with detectable antibodies compared to only 88% of them already received any vaccine or had a history of COVID-19. But among older children and as well adults and elderly, we found the proportion of detectable antibodies to be slightly lower than the recorded vaccination history and also infection history. When we look at the neutralizing antibody, around 50 to 72% of all individuals who produce IgG also producing neutralizing antibodies. So there is also reduction of those producing the neutralizing antibodies. We also analyzed further comparing the IgG levels between age group and their history of vaccination, whether they received one vaccine, 1 dose, 2 doses, or 3 doses. So the lowest IgG level was found among children aged under 6 years old because they did not receive any vaccine yet. And in other age groups, the levels of antibody increased with the numbers of vaccine doses received, except that in the adolescent group, the 2 doses was not higher than among adolescents receiving 1 dose. And we found that the highest levels of antibody was among adults who have received 3 doses of vaccines. We also look at the correlation between age and the production of neutralizing antibodies, and we see lower proportion of neutralizing antibodies among children who has not been vaccinated, which means under 6 years old, and also we found it among adolescents. We also compare it again between the production of neutralizing antibodies with the status of vaccination and age group. And we found that the highest neutralizing antibody was produced among those who have received the 3rd dose. And this shows the importance of booster dose in the population. We also look at the level of antibodies produced among those with history of COVID-19 and without history of COVID-19 among those who have received the 3rd dose. And we found a much higher levels of antibodies among those who have received 3 doses and also with history of COVID-19. But when we look at the levels of antibody with time, since they received the 3rd dose, we found that the levels reduced with time. So the longer since they have received the 3rd dose, the lower the level is. And we want to do further analysis to see when actually these antibodies will reduce and impacts on severity of disease when they contract COVID-19. So as a summary, we now know that the high proportion of North Sumatra population has been vaccinated against COVID-19. The history of exposure by vaccine or also by natural infection is correlated with detectable antibodies, but only 50 to 70% would produce neutralizing antibodies. The durability of antibody level is determined by several factors, but one of them including the duration from the last vaccination time point, infection history, and much more. Although we know that the 2 doses or full doses of COVID-19 vaccine would make individual develop antibodies, but the 3rd dose increases the level of antibody levels. And we want to evaluate this association with protection. And before we decide whether we are ready to move to endemicity, population's high level of immunity is important, but it's only one factor, assuming that this high immunity will prevent high hospitalization and reduce mortality rates, and hoping there will be no new variant developed. But other factors that we have to consider, including integrated public health interventions in the community. We need to have a more prepared health system and have community trust so people would want to be vaccinated. And this is something that we have to make sure is ready while the cases are low, because we cannot make them ready when the cases are already very high or while we are in the pandemic era. And we also need to have vaccine equity. We need to make sure that everyone in every region have same access to vaccine, because those who don't receive vaccine would have the higher probability to make a new variant emerge. And we also need to have effective treatment, so those who are at risk to have severe disease can get the best treatment. Thank you very much. That's all my presentation.
Thank you very much for the excellent talk and insights, Professor Inke, on a very important zero surveillance study. And I'm sure that our participants have also benefited greatly from your sharing. We'll leave questions to the end, as I earlier stated, and I am now pleased to invite our second speaker, Professor Wang Ji from the Institute of Precision Medicine, the first affiliated hospital of Sun Yat-sen University. Professor Wang obtained his PhD from Tsinghua University and received his postdoctoral training and served as a faculty member at Harvard Medical School. His research focuses on developing next-generation vaccines and immunotherapy via multidisciplinary approaches, including immunology, chemistry, and biomedical engineering. He has published more than 30 peer-reviewed articles in journals including Science and Nature Nanotechnology. And Professor Wang will be sharing with us today on the topic of robust induction of B and T cell responses induced by a third dose of inactivated SARS-CoV-2 vaccine. Professor Wang, please.
Thank you, Louisa, for very nice introduction. So everyone, can you see my screen?
Yes, could you play the slideshow?
Okay, so let's begin. So it's my great pleasure to give this talk in this AAHCI webinar. And on behalf of Dr. Xiaohai Peng, our team leader and president of FAH, and also on behalf of our team members. And today I'm going to talk about robust induction of B cell and T cell responses by a third dose of inactivated SARS-CoV-2 vaccine. Well, first of all, I would like to introduce the inactivated vaccine. So the SARS-CoV-2 virus comprises a number of viral structure proteins, including S protein, envelope, nucleocapsid, and membrane proteins. And among these proteins, S protein, the spike protein, might be the most famous one. The vaccines such as BNT162b2 and mRNA-1273, those mRNA vaccines and those viral vector-based vaccines all express the S protein, use S protein as a major antigen. Very different from those kind of vaccines, the whole inactivated SARS-CoV-2 vaccine, such as BBIP2-CoV or CoronaVac, comprise all of these viral structure proteins. And based on the study on the viral infection and based on our experience on influenza vaccines, we find that besides the S protein, other proteins such as nucleocapsid may also contribute to the protective immune responses. And some of those proteins, such as NPS, are conserved among variants of concerns. So would be another good target for vaccines. So the current study is based on our previous cohort. We have previously conducted a non-randomized trial and recruited a number of healthcare workers from a prospective cohort. We have demonstrated that the impact of a circadian rhythm on the immune response induced by the primary two-dose series of the inactivated SARS-CoV-2 vaccine. And here, the 50 healthcare workers were volunteered to participate in this study to investigate the duration of the primary vaccination regimen and the potential benefits of a third dose. First, we found that the third dose is quite safe. No severe side effects related to the vaccination were recorded during the trial. So next, we collect blood samples from multiple time points before and after each dose, and the neutralizing antibodies against the receptor binding domain were measured by a competitive assay. We find that the mean serum concentration of receptor of RBD neutralizing antibodies dropped by 70% from day 56 to day 180, that is 1 month after the second dose to 5 months after the second dose. So there's a waned immune response. The third dose is quite effective in augment or in recall the immune response. We find the mean concentration of neutralizing antibodies was increased by 7.2 folds from 8.8 AU per mil 5 months after the second dose to 3.6 AU per mil just 1 week after the third dose. We've also found that the third dose not only elevates the neutralizing antibodies against the wild-type SARS-CoV-2, but also strengthens a cross-protective immune response against a number of variants of concerns, such as Delta and Omicron. We find the mean serum PVNT50, that is neutralizing titers against pseudovirus. The PVNT50 against the Delta variant was increased by 10-fold, while the neutralizing antibodies against the Omicron variant were elevated by 19-fold. As I mentioned previously, so the one potential advantage of inactivated vaccine over other vaccine types is that they compress all of various structured proteins, which may also contribute to a protective immune response, induce a broader spectrum of immunity. So we measured the immune response against the multiple antigens by ELISA, and we find that the third dose of BBIP-CoV successfully elicited antibodies against all structured proteins and subdomains tested. We find the third dose profoundly augmented the immune response against S1 domain of spike protein, which compress NTD and RBD subdomains. And NTD, especially RBD domains, are very important, are crucial for the neutralizing against the virus. In line with robust antibody responses, we find that the memory B cells were also recalled and expanded efficiently by the third dose. We find the third dose increased the percentage of spike or RBD specific memory B cells by 1.7 and 2 folds just 1 week after the third dose. And we also find the third dose boosted spike and RBD responsive and IgG secreting B cells by 2.1 fold or 2.7 fold respectively. So we need to have memory B cells, and we also confirm those memory B cells are functional, can secrete IgG when they encounter antigens. Besides B cell responses, we also find the cellular arm of our immunity also being effectively recalled by the third dose. We found the third dose induced expansion of spike-specific CD4 T cells by 5.9-fold within just 1 week after third dose. And among those various specific CD4 T cells, about 57% of cells were circulating follicular helper T cells, which is the counterpart of TFH cells in our lymph nodes, which is in line with our result that the B cells has been effectively expanded and the humoral responses were effectively recalled. Besides the CD4 T cells, which is the helper T cells, we found the CD8 T cells, which are effector T cells, were also effectively recalled and even elevated by the third dose. First of all, we use activation marker to identify those T cells. We find CD8, CD69, 41BB T cells were seen on day 180. That is 5 months after the second dose, which is unexpected because such a long time, but those cells are still existed in our circulating system. And the third dose further elevated these T cells by 2.7-fold, just 1 week after third dose, which we think would certainly strengthen our protection against severe disease or fatal diseases. We also confirm the function of these T cells by intracellular cytokine staining. We find CD8 positive, interferon gamma positive T cells were detected on day 56, which is 2 weeks after the 4 weeks after the second dose, and these T cells decreased over time till the third vaccination, and the third vaccination elevated interferon gamma expression CD8 T cells to a greater extent when compared to that on day 56. Well, by this study, we have found that the third dose are very effective and safe in recalling our B cell and T cell responses. And next, I will spend 1 minute to discuss this result with the real world data from Hong Kong. Early this year, this Hong Kong experienced Omicron predominant period, and this clinical study find that the 3 doses of inactivated SARS-CoV-2 vaccine offer very high level of protection among severe outcomes. If we take a look at the data from 2 doses, we find 2 doses of inactivated SARS-CoV-2 vaccine are quite effective against severe and fatal diseases in population under 60 years old, but for elderly, the efficiency decreased. In people receiving 3 doses of inactivated vaccines, we find in all age groups, those vaccines are highly effective. And as effective as those people received 3 doses of mRNA vaccines, which is coincide with our immune response data that both B cell and T cell responses are recalled and elevated by the third dose. Last, I would make a summary. The third dose of inactivated SARS-CoV-2 vaccine is safe and effective. The waned humoral immune response was vigorously elevated after the third dose, along with abundant spike-specific circulating TFH cells in parallel. The spike-specific CD4 T cell and the CD8 T cells were also robustly elevated. Expansion of memory pools by the third dose could potentiate greater durability of protective immune responses. And this data, most of this data has been published in this paper. If you are interested, please read it. And lastly, I would like to thank our team members. This study is led by Professor Xiao Haipeng and other professors, and Professor Zhang Hui and Professor Peng Sui also contribute significantly to this project. And we also would like to thank Professor Yu Jun from Chinese University of Hong Kong and Professor Lulu from Fudan University for his support on pseudovirus assays. And lastly, I would like to thank Sun University and the First Affiliate Hospital and the Guangzhou Science and Technology Program for the funding support. Thank you all for listening.
Thank you very much for that very educational talk, Professor Wang. The immunology is a complex topic, and I think that it's very important and helpful for us to understand the different cellular responses to different vaccines. So thank you again. And next, I'm very honored to hand over to Dr. Rima Moynier, who is an infectious disease specialist and prolific researcher who has been practicing medicine in Lebanon since 1996. She has assumed leadership positions in infection prevention and control and antimicrobial stewardship in several tertiary care hospitals in Lebanon. Since 2018, she has been appointed as an external consultant by the World Health Organization to help health officials in several Middle Eastern countries develop their national action plans for the control of antimicrobial resistance. Dr. Rima's research interest is multidisciplinary, where she has principally co-authored more than 40 publications in reputed peer-reviewed journals in the field of infectious diseases. Dr. Rima's talk today is entitled An Overview of Heterologous Vaccination Against COVID-19, and I'm sure this is a topic of great interest to many as well. So Dr. Rima, please. Dr. Rima, you need to unmute yourself. I think it appears that you're still muted.
I had to stop the screen share, okay, to be able to unmute. Okay, just a second, I'm sharing my slides. Okay, can you hear me now?
Yes.
Yes, we
Can you hear me now? Yeah,
Yes,
thank
we
you.
can hear you.
Thank you very much. I would like to thank the panel for inviting me to present our data from joint work between the American University of Beirut, the Arab University Maqasid Hospital, and the Army in Lebanon. These studies were done under the supervision of Professor Mohammed Sayer from the American University of Beirut. So I will start presenting our data about the heterogeneous vaccinations, and these are my disclosures. And I would like first to have a quick look about the world vaccination and show how much in the whole world people
Dr.
are getting.
Rima? Dr.
Yes.
Rima, sorry to interrupt you. We don't see your slides. Do you want me to go ahead and run them for you?
No, I'll try again because Okay, please run them and I'll skip some of them. Okay, please run my slide.
Okay, just let me know when to go to the next slide and I'll follow. Thank you.
All right. Okay, next, please. Go to the next, please. Next, please. Yeah, here, please. Would you please put full screen? Okay, if we look at the world population, we see that 65% of the world population has received at least one dose of COVID-19 vaccine by April 9, 2022, and 58.9% have received a full vaccination of 2 vaccines, and 22% of the world population has received the booster. And next, please. And if we look at, next, please. If we look at the next slide, please. Next, please. Slide number 5, please.
1 second, sorry. We're having issues.
Juma. Okay, thank you. If we look at where are the people that are vaccinated, we see that there is no real equity in the world about the vaccine distribution. We see that most of the Western world and in the Asia Pacific, there is a high rate of vaccination compared to other areas of the world. And the issue of vaccine equity has been a very hot issue during the pandemic, not only for equity per se, but as we know, like areas with low rates of vaccination are hot areas for cooking new variants that can come back to the areas with high rate of vaccination, and this would keep the pandemic running. So we need all efforts that are available in order to have a high rate of coverage by the vaccine. Next slide, please. If we look here, we see that in areas with the low-income countries have the lowest rate of vaccination compared to areas with high-income countries. Next slide, please. And if we look at next slide, please. At the available vaccines in the world, we have the mRNA vaccine presented by the Pfizer and the Moderna. I will keep by the names of the vaccine rather than the scientific name because it's easier and everybody knows the vaccines by their names. So we have the mRNA like Pfizer and Moderna. We have the recombinant vaccines, the adeno-recombinant vaccines like Oxford, AstraZeneca, Johnson, and the Sputnik vaccine. And then we have the whole cell vaccine, vaccines like the Sinovac, Sinopharm, and we have the recombinant spike glycoproteins like the Novavax. So we have a full armamentarium of vaccines that we really need to exploit and like whip the horse with these vaccines in order to have the best coverage to have the full equity in the world. So next, please. Next, please. Heterologous vaccination, by definition, is to give two different vaccines, two vaccines from different platforms, or two different vaccines even from the same platform to the first same individual. We have heterologous vaccination that involves the primary vaccination that is of the first two vaccines, or heterologous vaccination that involves the booster vaccine that is to give the different vaccine after the two primary vaccinations that are in the primary vaccination. Next, please. Next, please. So in the heterologous vaccination, when it's in the boost, in the primary vaccination, it's like giving first AstraZeneca and then Pfizer, or when it is a heterologous vaccination in the boost, like for example, when to give Sinopharm, and then the boost is Pfizer. There are plenty of examples and plenty of matches that one can do, and we'll have a look at our study where we have done a lot of matches and withdraw some conclusions. Next, please. In the world, when we mapped the literature while preparing for this presentation, we found plenty, like 24 articles describing heterologous vaccination and the primary vaccination, and most of them were when there was a first ChAdOx vaccine, the AstraZeneca vaccine, followed by the second dose by the mRNA, and this was done due to the coagulability problem with the ChAdOx vaccine. And there were few other studies and trials in the literature that involved other types of vaccination. Next, please. Next, please. Next, please. So this is a pivotal trial where in the UK, they tried after the giving the Chadox vaccine, the AstraZeneca, the mRNA vaccine was given in the primary vaccination. And they looked at the reactogenicity, the side effects, and how safe it is, and on the immune response that is triggered by this vaccination. Can I have the next slide, please? Next, please. So when we look at the, no, the first one, please. The previous one, please. Okay, never mind. Yeah. When we look at the anti-spike IgG, many studies have shown a high correlation between anti-spike IgG and neutralizing antibody, mainly before the emergence of the variants of Omicron and Delta. And many people have tested the immunogenicity of the vaccine by measuring the anti-spike IgG by different modalities from Roche, from bioMérieux, and other laboratories. We see here that if we look at this here, we see we have Chadok after Chadok, mRNA after Chadok, Novavax after Chadok, or BioNTech, mRNA after BioNTech, or Novavax after BioNTech. When we look at Chadok, this is the gray one, and BioNTech, this is the yellow one. So when we compare to monologous vaccination, which is Chadok, and BioNTech, we see that the brown one, which is BioNTech, with another type, which is BioNTech with Moderna, gives a higher immune response. So heterologous from the same class has shown a higher immune response compared to heterologous from the same vaccine. And when we look here at the blue one, when we see Chadok followed by mRNA vaccine, we find a higher response than Chadok, but still lower than BioNTech. And we look at the green one, when Chadok was followed by the Novavax, which is a glycoprotein, gave a lower response than Chadok BioNTech, but equal or more or less equal to Chadok. And the purple one was BioNTech was followed by a Novavax. It gave a lower response than BioNTech. So the conclusion is that heterologous vaccination can give different immune level, IgG level, with different types of boosters. And this is very important. This importance appeared later when, with the Omicron variant, the studies have shown that we really need high level of IgG, not only the presence of the IgG or the availability of the immune response, but really a high level of immune response in order to neutralize the virus and in order to prevent infection. The issue of preventing severe infection or hospitalization is not the same. This might be available, as we have heard from the previous speaker, from lower levels of IgG. But however, infection prevention, we need to have really high levels. So choosing which vaccine in order to prevent infection, it depends a lot on which vaccine we are priming with and which vaccine is the second vaccine. So in this slide, we see that heterologous vaccination can give different level of vaccines, and the highest one was given when the mRNA vaccine was used as the boost vaccine. Next, please. Next, please. The next, please. Skip this one, please. Yeah. We did our data. We have boosted a few people with the Sinopharm. The first dose was a Sinopharm vaccine, which is a whole cell vaccine. We have compared them to giving 2 Pfizer vaccine or just 1 Sinopharm and 1 Pfizer. So this heterologous vaccination in the primary vaccination, and we see here that the response after 2 Sinopharm vaccine was comparable to 2 Pfizer vaccine. So in terms of equity, if we cannot provide a lot of mRNA, like mixing 1 Sino with 1 mRNA vaccine might give the same effect of 2 mRNA vaccine, and might decrease the need of the mRNA vaccine by half if we need this level of IgG for the immunity. Next, please. This is a heterologous vaccination. Now we go to the vaccination in the boost. And also when we map the literature, fewer studies were mentioned, but the most common were when the primary vaccination was boosted by mRNA vaccine, and the primary was an inactive, double inactive vaccine, and then boosted by an mRNA vaccine, and a few other studies as well. Next, please. I will show you. This is the pivotal study where the boost was given in the heterogeneous vaccination, and I will skip a few slides for the sake of time. Next, please. Next, please. So the participants here, received either 2 Pfizer followed by any type of other vaccination with different doses, or 2 Chaddox vaccine followed by a booster from different classes and different doses. And I will show you a few of the results. Next, please. Next, please. So in terms of safety of the 7 different vaccines, the three vaccines showed overall increased side effects, and they were, when AstraZeneca was given after Pfizer, the side effects were really high. The Janssen after Pfizer was high. So mRNA after, recombinant adenovirus after mRNA gave a high level of side effects. Also, mRNA after Astra or Pfizer gave a high level of side effects. That's why a Moderna vaccine now, whenever it's given in the boost, it's given in a reduced dose. Next, please. Next, please. Next, this is the map of the study where they have people who have received the Chaddock, and they were given as a boost either Pfizer or AstraZeneca or whole cell vaccine. And just to summarize, we see that the highest immunogenicity was given, next please, when the mRNA, next please, when mRNA vaccine was given. Much lower much lower immunogenicity was given when the recombinant vaccine, adenovirus vaccine was given, and much lower immunogenicity was seen when the inactive vaccine were given. This is when the Chaddock prime population was given a boost. We will skip 3 slides, please. Skip, please. Yeah. Skip, please. Skip, please. Next slide, please. Next. Next. So among the trial, the previous one, please. The previous one, Among the trial participants who initially received Pfizer, a third dose of all vaccines tested except Valneva, which is a whole cell vaccine, induced significantly higher levels of anti-spike IgG compared to the control. However, the highest boost, the highest level was obtained when the boost was an mRNA vaccine. Next, please. Next. When we look at the T cell, the previous one, please. When we look at the T cell response, however, we see that the T cell response was highest when the primary vaccination was a Chaddock vaccine compared to the primary vaccination when it was an mRNA vaccine. And when the boost was a Chaddock in the mRNA vaccine, the T cell was higher. So the T cell with the Chaddock vaccine, with the recombinant RNA vaccination, was higher than the T cell response with the mRNA vaccine, while the humoral immune response was higher with the mRNA vaccine compared to the Chaddock vaccine. Next, please. I'll go now quickly to our data. So this is our population. We aim to check the heterogeneous vaccination in the population of the Army, where people got different types of boosts. And next, please. Next, please. Here, this is the first study where we compared the previous one, please. Yeah. So we compared 2 Pfizer vaccine in the IgG level, 2 Pfizer to 2 Pfizer after 3 months, 2 Pfizer after 6 months, and this is the boosted 2 Pfizer, which gave a higher immunogenicity than 2 Pfizer at the beginning. And this is why the booster vaccine was more effective in the community in preventing infection against Omicron than the 2 Pfizer vaccine, because we need higher IgG level. This coincides with our data. So boosting an mRNA with an mRNA give a high level IgG level. Next, please. Next, please. Then we looked at when we boosted 2 Pfizer with 1 inactivated vaccine. And we see this is 2 Pfizer after 3 months, after 6 months. And when we boosted with an inactivated vaccine, the Sinopharm, nothing happened. Really, the level did not go up, did not even reach the 2 Pfizer vaccine. So with boosting this, the mRNA with Sinopharm did not lead to a high level of anti-spike immunoglobulin. Next, please. We looked here at the Sputnik compared to 2 Pfizer 6 months, 2 Pfizer 3 Pfizer. And for the Omicron, we wanted to reach a 3 Pfizer level. 2 Sputnik after 4 months was much lower than 2 Pfizer after 2 months. And the 2 Sputnik with 1 Pfizer showed a level comparable to 3 Pfizer. So Sputnik, when it is people are primed with 2 Sputnik, giving a booster of mRNA vaccine would be enough to match a 3 Pfizer vaccination. Next, please. Next, please. Okay, next, please. 1 Sino, 1 Pfizer, and 2 Sino, 1 Pfizer gave very high level as well. Next, please. Next, please. So mixing is safe. The conclusion, mixing is safe. The second conclusion, the mRNA vaccines are best used as boosters. The Chadok vaccines, they produce the highest level of T response compared to the mRNA vaccine. The inactivated vaccines represented in our study by the Sinopharm did not induce an increase in immunoglobulin when it's given as a booster. And so our conclusion, the Chadok and the inactivated vaccine would be the best as primers, and the mRNA vaccine would be the best to be used as a booster vaccine. I will stop here for the sake of time, and thank you very much.
Thank you so much for a great talk, Dr. Rima. And this has also been a topic that has garnered much interest since the start of the various vaccine rollout. So we're very, very glad to be able to revise and also gain much more knowledge on this today. And last but not least, we are very pleased to be joined by Associate Professor Hari Hendarto, who is the current Dean of Faculty of Medicine at the Universitas Islam Negeri Syarif Hidayatullah Jakarta, as well as serving Hospital Chief Executive of Jakarta Hajj Hospital. Prof. Hari received his medical education in Indonesia with a postgraduate focus for internal specialization and a PhD graduate in diabetes and endocrinology that he completed at the University of Kyushu in Japan. Professor Hari will be sharing on the Faculty of Medicine UIN Jakarta experience on COVID-19 examination and vaccines. Over to you, Prof. Hari.
Okay, thank you, Dr. Lucia, for your nice introduction. So, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. So, it is a great pleasure for me to sharing my slide about experience handling COVID-19 in my University UIN Jakarta. So, can everybody see my slide?
Yes.
Okay, thank you. So what I present is about COVID-19 examination and vaccine, Faculty of Medicine UIN Jakarta experience. So the COVID-19 was first reported in Wuhan, China in December 2019. This disease is caused by novel coronavirus SARS-CoV-2, which leads to severe acute respiratory syndrome. And the WHO officially declared the COVID-19 as a global pandemic on March 11, 2020. So in April 2022, in Indonesia, around 6 million people were infected and 155,000 people were dead. As we see that there were 3 waves of COVID-19 infection in Indonesia. So first wave in January 2021, second in July 2021. So first let me focus in this first and second wave. So as we see this, in Indonesia faced the first wave of COVID-19 infection on January 2021. This happened after the Christmas and New Year holiday. So the highest new case per day reached the peak of 89,000 cases. And by strict discipline of health protocol, including the correct use of masks, diligently washing hands after handling objects, and maintaining distance from others through reduced mobility, then in May, number of new cases fell to 26,000 cases per day. So Indonesia to succeed handling the COVID-19 pandemic. Is it? So if we sit on July 2021, Indonesia was bracing for the second wave of COVID-19 infection as the Delta variant drive a surge in the new case in Indonesia. So how did Indonesia get from relative calm in number of cases in May 2021 to its new crisis in July 2021? So experts said that the crisis is because of the loose restriction on movement after we saw that we succeed handling the first wave. The workplace, market, and malls have already reopened. And transport is operating at full capacity. And also big wedding, festival, and election rallies are also being held. So another was also there's Eid al-Fitri big holiday in Indonesia in May 2021. So this Delta variant of COVID-19 is causing an escalating crisis in Indonesia, while number of new cases have rising sharply to 250,000 new cases per day and are continuing to do so. So hospitally become overwhelmed by 6 patients and run out of bed. Medical facility for being under pressure, unable to cope with the influx in patient. Oxygen tank supply were rolled out everywhere. And patient had to wait for days before can being admitted. So burial ground are full everywhere. Many people have died at hospital or at home. Before, it was a very sad moment at this time before the second wave slowing down on August, September 2021. So now actually Indonesia was bracing for the third wave of COVID-19 infection as the highly transmissible of new Omicron variant derived surge in new case in Indonesia. So actually Indonesia has just recovered from last year's spike caused by Delta variant. And that was among the worst in our country, and daily infections have fallen to about only 200 by December 2021. But again, the cases are rising again just week after the Ministry of Health report its first local Omicron transmission on Indonesia on December 15, 2021. But interestingly, although it was the highest daily new case load compared to July 2021, when Delta driven third wave, total number of death cases was dropped to lower limit. Is it we thought because Omicron variant caused less clinically symptom than Delta variant? This third wave Omicron did not push Indonesia healthcare system to the brink. An asymptomatic patient could just go to self-isolated at home and use telemedicine service through the which they can access doctor, medicine, and vitamin, etc. for free. So globally, the WHO has set the vaccination target 10% of each country population by September 2021 and 40% by the end of 2021, 70% by the mid of 2022. So we see in this graphic, Indonesia almost vaccination target above the 70% for the vaccine first shot and second shot, but for the booster, the third shot, only around 12%. So less than 13% of the target population has received the third shot of COVID-19 vaccine. So one explanation that the incidence of adverse effect following immunization, COVID vaccination, show an important impact on the level of public confidence in the benefit of participation to get the shot of this vaccine. So this UIN Jakarta responds quickly to the government program to carry out the vaccination program to general public. We also encouraging all of student, lecturer, teaching staff, and local community to receive their COVID-19 vaccination as first, second shot, and booster as soon as possible. And also to assist the government in accelerating the vaccination program of 1 million per day, in Jakarta, in collaboration with the Tangerang District Health Office, sent 60 vaccination volunteers for 35,000 people in 9 sub-districts in Tangerang region to be vaccinated. So total we have around 30,000 students in UIN Jakarta, and during the COVID-19 outbreak, around 1,000 students, including international students, who are still staying in the dormitory, and some in around the campus area. So therefore, UIN Jakarta distribute the food package to students affected by the COVID-19 outbreak. More packages were distributed to the campus security guard who had been actively helping to prevent the spread of the deadly virus in the campus environment. So to assist the government in serve and carrying out the COVID-19 molecular examination, UIN Jakarta on the Basel COVID-19 integrated laboratory with mixing and at arena and PCR room facility. This integrated laboratory serves as a COVID-19 PCR examination network in the Banten province region. So as a potential COVID vaccine developed by the biotech firm affiliated with China Lipton Pharmaceutical Group, has already trialed in over 10 countries. So, and have been approved for phase 3 clinical trial in 6 universities in Indonesia. So including UIN Jakarta as one of the 6 universities in Indonesia. And now the research about this vaccine is still ongoing. We Jakarta have launched also some research project as part of the global response to COVID-19. Some research aim to understand after effect, other aim to understand how do people human system respond, and etc. etc. So last update in Indonesia in March 2022, national active COVID-19 cases have gone down by 83% as of April from the most recent peak caused by the Omicron variant. And the number of COVID-19 patients being treated in hospital has fallen by 85%, with bed occupation rate of only 6%. And while the number of deaths caused by the coronavirus has fallen by 88%. So Omicron wave is characterized by a surge in case and then a decline within a short period of time as seen in Indonesia. And following improvement in the national COVID-19 situation, Indonesia will relax health restriction. So Indonesia appears to have passed the peak of the surge in Omicron case, but we must still remain vigilant. Easing mobility restriction for economic recovery must be accompanied by the health protocols. And health protocol, vaccine, and booster is a must. So thank you everybody for your attention. Thank you.
Thank you so much for sharing your university and hospitals experience, Professor Hari. I'm sure we've all been through some very, very challenging and devastating times with COVID, but such sharing offers valuable lessons to be learnt by all. So we will now open the floor to our audience for questions. Please do kindly type your questions into the Q&A function if you have not yet. If there are too many questions, we may not be able to get through all of them at the end, but I'll try to pick out the most popular themes and hopefully we'll be able to cover fair ground there.
Hey, Luisa. Oh, sorry.
Yes,
so can you give me 1 minute because I just saw Dr. Harito's PPT and I find some problem. So I have to clarify that the first COVID-19 is not originated from Wuhan city. It is, yeah, it is Wuhan city that report the first COVID-19 case, but it doesn't mean that the COVID-19 originated from Wuhan. So I have to clarify that. There's a lot of substantial evidence indicates that the SARS-CoV-2 is originated from nature, and maybe the first COVID-19 case existed several months before the first report in Wuhan. So I have to clarify that.
Okay, thank you, Professor Wang, for your clarification. Thank you.
Yeah, because because this is a lot of audience here, so we have to make it very clear.
Yes, thank you very much, Professor Wang. So I'll now move on to our first question from Dr. Sonu Bhaskar. She first put it into the chat. So she says, thank you very much, Professor Inke, for an interesting and important piece of work shared. And her question is, what is the seroprevalence data analyzed according to, was it also analyzed according to social economic groups? And it would be interesting to explore variation across these groups and also the gaps between the dosages and to inform public health strategies.
Yes, thank you so much, Dr. Louisa, and thank you for the interesting question. Unfortunately, we did not collect the information about the socioeconomic. We also did not collect any other information that can affect the development of the antibodies levels, including like malnutrition status as well as co-infection, because it's going to take a lot of time to collect all those data. But thank you for the suggestion, and because we are planning to follow up with the study, so we can collect more data in the future.
Thank you very much, Professor Inke. And our next question is from Teresia Santi. And she says, thank you for the interesting presentation from Universitas Sumatera Utara and what methods were being used for the neutralizing antibody assessment. And how about the correlation between the neutralizing antibody and antibody titers IgM and IgG? So still Professor Inke, please.
Yeah, so we performed the CLIA to analyze the neutralizing antibody, and the difference with the neutralizing antibody from the IgG and IgM. So the levels or detection of the IgM IgG does not necessarily mean that the body will prevent the body from someone from getting severe infection, because it doesn't mean that it will neutralize the infection. But we also have to be something I want to mention, that we also need to know that evaluation on the IgG and IgM can still cross-reactive with other diseases. So for example, like countries in the tropics, there are some reports that the evaluation on, there is a cross-reactivity between the SARS-CoV-2 with malaria and also dengue infection. So in country like Indonesia, where we have a lot of dengue and also malaria in some regions, when we found higher levels of immunity against the COVID-19, we need to make sure this is not a cross-reactivity or cross-reactivity with these other diseases. Regarding the difference of the neutralizing antibody with other antibodies, I think Prof. Wang and also Dr. Rima probably can answer better than me, as they are the experts here. Thank you.
Would anyone like to follow up on that question regarding the difference between the neutralizing antibodies and IgG and IgM?
Yeah, so in our study, we find maybe in the first two doses, there's some correlation between the IgGs and the neutralizing antibodies. But as we continues for the third dose or fourth dose, maybe the correlation lost, because there's a lot of things could affect the neutralizing activities, such as the amount of antibodies, as well as the affinity of the antibodies between the antigens and the antibodies. So it's a lot of things may disturb, complicate this correlation.
May I add that also it varies with the variant. So the neutralizing antibody of the IgG and IgM against the alpha variant would not be the same as against the Omicron variant, which makes it that's why we need a very high level of IgG in order to neutralize the Omicron variant compared to the previous variants. So it's also variant dependent on top of all the other factors that were previously mentioned.
Thank you very much, Professor Wang and Dr. Rima, for your inputs as well. Professor Wang, if you don't mind, and then following up with the next question that's addressed to you, it's from Aida Bagus Usada, and she asks, how long will the protective effect after the third vaccine to the infection with COVID-19 or its variants last? Thank you. So Professor Wang, that question is just for you. So how long would the protective effects of the inactivated vaccines last after the third dose, if you have any data on that?
Yeah, we have some data on that. If you take a look at our new preprints on the medRxiv, we have do that. We find the immune response, particularly the humoral immune responses went after 6 months. This is like we have like 30 or 40% of immune response compared to the peak after the third dose. That is humoral immune responses. But we find that the T cell responses sustained for a longer time, as what we have seen after the second dose. I think that's why. So we can see we saw a very high level of protection in Hong Kong. I think we cannot just consider the humoral immune responses. We have to consider the T cells responses as a whole. Yeah.
Yes, indeed. As I mentioned earlier, the immune response, especially to COVID infection and vaccinations, are quite complex. And we know that apart from T cells, B cells, there are also memory B cells. So all that has to be taken into account to understand what our immune responses are. Yeah. So I think that we have a quite high level question, and I think that Professor Wang may be the best person to answer it again. Shahid Rido asks, can dendritic cells be used as a vaccine?
Yeah, that's a good question from I think expert in immunology. So definitely we can use dendritic cells. We can mount dendritic cell with antigens and inject into our body. That's what have we done in cancer immunotherapies. That is quite effective for inducing CD8 T cell responses. But the problem is at the current stage, this strategy is quite expensive. It's quite expensive for everyone to use. So I think maybe now it is best for the cancer immunotherapies, but not for the large scale immunization on the populations. Yeah. I think that should be one of important direction for future if we can lower the expense of this strategy.
Thank you, Professor Wang. And there is a question from Budi Santoso. I think that this is probably addressed to either Dr. Rima or again Professor Wang. It says, with that data, do you have anticipated and predictions for this year for the possibility of the fourth wave? And what is the best strategy for anticipating that condition? I suppose that he's referring to the immune responses we see or the studies of the heterologous vaccination strategies.
Okay.
Perhaps we can start with Dr. Rima, if you have any insights as to how you might anticipate that acting out if there is a fourth wave.
Okay, the emergence of the Omicron variant and the wave driven by the Omicron variant gave a natural boost to those that did not receive the third or the second dose or those that were not vaccinated. However, whatever the immunity is, that the effect of this natural boost or the third dose vaccination, the prevention from infection wouldn't last more than 3 to 6 months at most. So if there will be another variant, we don't know, but if there is another variant, there might be a fourth dose, and the emergence of a new variant is not something that's not expected. So it depends on the variant that will come, whether it will be really virulent or not. This will answer the question of the importance of the fourth dose, a fourth wave. But having a fourth wave of a new variant that might be like the Omicron and that might become like a regular upper respiratory infection is the most probable scenario. However, we cannot just rely on this. We have always to be prepared for a more virulent variant. So the best thing is to keep surveillance, very active surveillance, and very really open eyes about the mortality and the increase in morbidity with whatever new higher numbers can occur, and in this case to start mass vaccination again. So do we need a fourth vaccine or not? Definitely the immunocompromised and the more elderly population, those at risk of having complicated infections, even with a mild variant like the Omicron, do really need the fourth dose in order to keep up their high immune level. But to give it to everybody, I would rather wait for the emergence or the having some variant of concern that might appear. So this is the way I see things from now on.
Thank you. Very well answered, Dr. Rima. And if you don't mind, I have a personal follow-up question on vaccinations as well as infection as well. I think earlier on, Professor Shane Cotty's lab had shared that infection before vaccination actually will create a very powerful hybrid immunity response. However, infection after vaccination negates that response, and you don't get much or too much of a boost after. However, as we have seen, many people have gotten infected either with no matter what variant, they still do get a little bit of a boost in their immunity. And I wonder whether you have any data and experience as to whether this holds true across variants, and whether it is true that if we have an infection after getting 2 doses of, for example, an mRNA vaccine, that we don't need to necessarily consider the 3rd dose, or would that still be recommended regardless of our infection status?
Okay. Our data has shown that those who were infected and who have received 1 dose or 2 doses or even 3 doses of the vaccine, they mount a much higher immune response compared to those who were not infected. So I wouldn't be able to comment about the T-cell response because we did not work on it. However, definitely with the humoral response, those that were infected, they mount a much higher immune response. So this brings us to the question whether people who were infected and got 2 doses, do they need a 3rd dose, or 1 dose is enough, or etc. So this really depends on the variant. The picture is not 100% clear with the Omicron. However, people who were previously infected and who had 2 doses of vaccine, 6 months after the 2nd dose of vaccine, had really very high levels of antibodies that were comparable to those who have taken the boost. Maybe they might last less. This more studies will show it. So the WHO has recommended a 3rd dose, and they say that people who are recently infected, the Omicron infection can be counted as a natural boost. So if people get a new infection during the Omicron wave, there is no need for them now to take the 3rd boost, because the natural infection could work as the 3rd boost. I hope I have partially answered your question.
Yes, thank you very much, Dr. Rima. Okay, now I will move on to another follow-up question by Dr. Sanu Baska. She's addressed it to all panelists, but I would first like to invite Dr. Hari to answer it, as it is very close to his talk that he has shared. So the follow-up question is, what steps has MENA region taken, especially for the academic health centers, to fight vaccine hesitancy and improve on our public communication strategies to encourage vaccine uptake, including that of boosters in the community?
Okay, thank you, Dr. Solubaska, for your question. I think the very important thing is we gave tailor message to specific group, and we focus on increasing vaccine confidence by making accurate, clear information of the importance of vaccination to the prevention of COVID-19. Of course, there's other variety strategy like we can respond to any adverse events and also emphasize to support the vaccinates and maybe leverage trust for vaccine endorsed. But I think the most important thing is communication, good communication. Thank you.
Thank you, Dr. Hari. And I know that Professor Inke at the end of her talk also mentioned this actually as one of the very important strategies moving forward is not to forget to address communications as well as one of the important factors of public health strategies. And so may Professor Inke also share her insights on this, please?
Yeah, I agree with Dr. Hari that like communication is very important, and because there are many reasons why some community have hesitancy against receiving COVID-19 vaccine. So we need to identify whether they actually are anti-vaccine group or because they're afraid of the side effects. And once we identify the reasons, then we can approach with different strategies to convince about the vaccination program. And this is very important because we also realize now in our province that it is very difficult to achieve the last proportion of people who have not been vaccinated yet. Like when we started the vaccination in the province, it was quite fast, like to reach the 50%, but then it went very slow because it's the remaining people who don't want to be vaccinated. And like to be able to really to make sure that everyone has the protection, we have to cover like the whole population by vaccination. So I think we really need to identify, we need to involve not only the doctors, but also anthropologists and local people to really understand the characters of each community.
Thank you very much, Professor Inke. I think you mentioned, so a common phenomenon that is seen that, we often reach a plateau with our vaccination rates after we reach about 50 to 60%. And this is why we also have been emphasizing in many countries that other public health responses need to work together hand in hand too, to really continue our pandemic response, and so that, we prevent our healthcare systems from collapsing. Does Professor Wang or Dr. Rima have anything to also share on this topic?
Thank you. Thank you. I have nothing to add. Yeah.
Professor Wang?
Yeah, okay. So I think that depends on how we expect. So the function, the outcome of vaccination, if our expectation is prevent infection, that is, we need to update our vaccines, and even we know there's a plateau, and after maybe the third or fourth dose, and if we continue vaccination, we still cannot achieve that goal. We cannot, in my opinion, we cannot use current vaccine to prevent the infection of Omicron or oncoming variants. But if our expectation is to reduce is a protective response against the disease, the severe disease or fatal disease, I think the current vaccines work well. And after a third dose, we just need to the further boost. We use further boost to record the immune response, to maintain the immune response in a sufficient level. And I think that is good enough. Yeah.
Thank you, Professor Wang. With that, we've now come to the end of the webinar. I would like to sincerely thank our speakers once again for all your excellent insights and sharings. And we really depend on all of you to continue to work and provide us with data moving forward so that we can learn much more about surveillance as well as vaccine responses and booster responses as the pandemic continues, even as we go endemic. And I would also like to thank our organizers, our host, as well as all our participants today for taking time out of your busy schedules to attend such a meaningful and educational event. Everyone stay safe and have a great evening. See you.
Yeah, thank you. Stay safe.
Thank you.
Stay safe.
Thank you, everyone.
Thank you, everyone.
Bye.
Dr. Lucia, Professor Wang, Dr. Inge.